This conference will now be recorded.
My dear friends, for the question, what is the threshold value for the fetal scalp lactate to expedite the delivery? So what is the threshold? When you take action, okay, so I suppose that you can write your answer in the chat box if you would like to. So guys, may I ask you if you would agree for the 4.9 as a threshold for the lactate? Yeah. So it's actually okay. This is the fetal blood sampling values. Okay, it's part from your feedback. Here, the pH values. So normal, if we consider it from the pH, so it's normal 7.2 or above, borderline 7.21 to 7.24, abnormal from 7.2 and below. If we consider the lactate as a level, so it's normal when it is 4.1, so lactic acid or lactate is acid. So when it is higher, so means we have fetal acidosis, right? So 4.1 or more, or less, so this is normal. Borderline from 4.2 to 4.8, and abnormal from 4.9 or above. So the higher the lactic acid, the lower the pH, or the higher probability of the acidosis, right, in the fetus. Clear, guys? Okay, so what action would you take based on each one of them? So if the fetal blood sampling is normal and the Ctg should continue, if the Ctg stayed the same, no change after a normal pH, so what is your management at that moment? Ctg stayed the same after the fetal blood sampling is normal. When will you consider repeating it? After 1 hour, after 30 minutes, or no repeat? Yes, excellent, Dr. Jabin. Yes, so it's after 1 hour. Yeah, so if it is borderline, as you can see, either the pH or the lactate, so what's your action if it's a borderline? Yes, this is after 30 minutes. Yes. So guys, because I have just received a question today regarding the fetal blood sampling and when to do it. Okay, so easily, very easy when you take the decision, guys. Fetal blood sampling, in some situation, you should be able to know if it is useful or not. Okay, useful to do it or not. Very important that you exclude acute events. There is no time for the fetal blood sampling. And in the same time, you should ask yourself whether it would be useful for this patient, not contraindicated, so I can carry on. So if I ask you guys about the contraindication to the fetal blood sampling, can you enumerate some of them? Contraindication to the fetal blood sampling. Yeah, so the contraindication would be if there is acute event first, please. Okay, so it's contraindicated to do it at all. Like, for example, you have a case of cord prolapse. Do you have the time now to do a fetal blood sampling to say no? If you have a case of ruptured vasa previa, do you have a time for fetal blood sampling? No. Do you have a time to do a fetal blood sampling in ruptured uterus? No. If you have acute prolonged bradycardia, do you have a time to do fetal blood sampling? No. So this is the first thing you should understand. What is a contraindication? Though I wouldn't think of the fetal blood sampling in this case, right? So placental abruption, cord prolapse, uterine rupture should not be done. When the whole clinical picture indicates that the birth should be expedited, like what? For example, the clinical picture says, for example, okay, you have a lady that she is not well during delivery and she's exhausted and associated with Ctg is abnormal. Will you perform a fetal blood sampling, or you should go for the cesarean section in this case? So in cases of exhausted mother and this first stage of delivery, will you go for cesarean section or will you go? Yes. Sometimes also would be like signs and symptoms or indication of cephalopelvic disproportion. So you have excessive caput. Will you do fetal blood sampling? No. You have a brow presentation. Will you do a fetal blood sampling? You have a face presentation. Will you do a fetal blood sampling? No. So there is some situation where the fetal blood sampling should not be done and it's considered a contraindication of it. So when it is useful, okay, I'll tell you guys, it is useful mainly if you are, for example, in the first stage of delivery, okay, you have abnormal Ctg, you have excluded the acute event, so no acute event, okay? You have excluded the CBD, no other contraindication like maternal infection or bleeding disorder, fetal bleeding disorder, okay? So you don't have any of these. It's only at Ctg changes, right? So with this Ctg changes, what is the guideline says? Says, for example, that you start with the conservative management, right? Conservative management, like changing patient position, maternal position, like if there is dehydration, so you will hydrate the patient, and so on, right? Okay, so no improvement. What you will do next? Fetal scalp stimulation, right? Right? Isn't it? Okay, so if the fetal scalp stimulation is not changing anything, still, what you will do? So you have no contraindication to wait in this delivery. You have abnormal Ctg, you have tried the conservative management, you have also the fetal scalp stimulation not working. So after I check everything, then I will go for, yes, the fetal blood sampling in this case. And the fetal blood sampling can help you to determine, guys, to determine what action you would take. Like what? Like, for example, shall I go for a cut-1 cesarean section based on fetal acidosis? Or shall I wait? Or even if I would go for a cesarean section, I would be able to decide the urgency of this cesarean section, right? So here comes the role of the fetal blood sampling. So it's not for every case. Some people, they think that whenever I have seen non-progressive labor, or a pathological Ctg, I should go for the fetal blood sampling. Please check whether it's appropriate or not. If you are trying to obtain a fetal blood sampling and is not possible, please go to the cesarean section, because you don't know whether the baby is distressed, is acidotic or not. So you have to go to the cesarean section in this case. Okay, Dr. Basma? So if it is failed, you have to go to the cesarean section. So pathological, here, this is the management based on the interpretation of the Ctg trace. As all of you know, that those are the two golden tables for the NICE guideline in management of labor. So pathological, what shall I do? If I have a pathological Ctg with abnormal feature or two non-reassuring features, I should ask for a review by senior midwife or obstetrician. If I am the obstetrician, then I will review the Ctg. I will exclude acute event. So, for example, cord prolapse, suspected placenta abruption, or uterine rupture. I will correct any underlying cause, such as hypotension or uterine hyperstimulation, like, for example, a patient on oxytocin. So oxytocin should be stopped. Start one or more conservative measures. Talk to the woman and her birth companions about what is happening and the preference into account, put her preference into account. If the Ctg trace is still pathological after implementing conservative measures, obtain a further review by obstetrician and senior midwife. Okay? Offer digital fetal scalp stimulation and document the outcome. If the Ctg trace is still pathological after fetal scalp stimulation, and I would like to add here a no contraindication. Consider what? Consider fetal blood sampling or expedite delivery. Right? So guys, can you see the role of the fetal blood sampling here comes after how many steps? How many steps before the fetal blood sampling? So 1, 2, 3, 4. Yes. Yes. So I would like everyone of you guys, please, to be muted. I have hear some echoes. So thank you very much. Yes. So it's preceded by 6 steps. And it's considered, so not mandatory in every delivery, because this will be based on the judgment about how is the case, no contraindicated, whether it will be useful or not. So may I ask, my dear friends, who I'm sure that all of one of you are perfect and will tell me, if you have pathological Ctg in the second stage of delivery and the head position is +1 and no contraindication for vaginal delivery. Yes, assisted vaginal delivery. Will you go here for the fetal blood sampling? No, fetal blood sampling in this time is not useful, because delivery can be expedited, right? You can deliver this patient, so why would I do a fetal blood sampling and wait and so on? So mainly its role comes when no acute event, no contraindication, and it's a pathological Ctg, usually in the first stage, first active stage, right? Okay, so can I perform a fetal blood sampling on 3 cm? Patient is in latent phase and 3 cm? No, no, it's not of the safety of the fetal blood sampling. Fetal blood sampling should be done when it is at least 4 cm, okay? So more than 3 and the patient in active stage. If you have a baby in the latent stage with pathological Ctg, so do you expect that this baby will handle the delivery? No. So yeah, this is the thing. So your decision of whether or not taking the fetal blood sampling will be simply follow the table and see whether no contraindication, no acute event, conservative management happened, fetal scalp stimulation happened, and no change, so I could consider the fetal blood sampling. And as I told you, mainly for the second stage of delivery, we go for the instrumental vaginal delivery. Okay. The previous exam question that you are trying to take a fetal blood sampling, but it's difficult, technically difficult. Delivery. Okay, so if it is technically difficult, it's delivery, right? Yes, excellent, everyone. Well done. So let's go back to our questions. I think we have cleared this one. A woman who is 25 weeks pregnant contact GP for advice as she had developed the rash after significant exposure to a child with chickenpox. The rash started 8 hours earlier and the blood is taken urgently at the GP surgery, which is positive for varicella zoster IgM. What is the correct management? So rash appeared. Is there any role for the immunoglobulins here? No. So if the rash is within 24 hours, then acyclovir can help. If the patient is below 20 weeks, consider acyclovir. If the patient is above 20 weeks, then treatment with the acyclovir. Right? Well done, guys. Yes. Which blood pressure parameter is most often associated with a stroke in patient with severe preeclampsia? Which blood pressure parameter will be associated with a stroke mainly? Guys, it's the systolic blood pressure when it is more than 155. Okay, because it would be considered as severe, right? We are touching the severe, right? So the high, the systolic blood pressure, this is the high possibility. Yes, Dr. Tasrina, severe is more than 160, but it's systolic blood pressure because this comes from a TUG article. Okay. So the high systolic blood pressure is the one higher associated with a stroke. Okay. Yeah, systolic blood pressure part is the one associated with risk of hemorrhage, especially in the smaller capillary and small arteries. Okay, so when the patient develop rash, Dr. Moses, then you have to act based on the rash. The patient has the disease already. It's not about the immunity at all. So a primate at 38 plus 6, admitted with history of abdominal pain and clear fluid leaking vaginally for 5 hours. She was low risk throughout the pregnancy apart from GPS bacteriuria. On examination, her observation on normal pulse rate, blood pressure, temperature. She's having regular painful contractions, 3 in 10, and their vital dilatation found to be 4. CTG was performed due to concern about the fetal heart, and the CTG showed baseline heart rate of 140 to 150 with no other non-reassuring or abnormal features. So what will be the next step? Next appropriate step in this case? So guys, what we know from the algorithm? Okay, guys, this patient is a GPS carrier, right? GPS bacteriuria during the pregnancy, right? She's now 38. So far, she's stable and baby is stable. Okay, so shall you await in this delivery with the BROM, or shall you expedite this pregnancy? No, it's not about the CTG at all, Dr. Basma, now at the moment. It's about the bacteriuria, the GPS bacteriuria with rupture membrane. Yes, you have to expedite the delivery, right? Yes, we have to expedite the delivery. Who is clever and will tell me this patient needs antibiotic prophylaxis during labor or not? Yes, excellent, well done. So it's not even mentioned in the options, but you know that it will be needed, right? So you might find another question with other option, okay, and this patient, she comes in labor and he gives you like expedite delivery and intrapartum antibiotic prophylaxis, so you know that she will need, right? The group B streptococcus, all the type of question are part of your exam. Okay, so all the situation, guys, read it carefully and apply the algorithm, okay? The midwife coordinator reports to you that a low-risk primate in 39 weeks in a midwife birth center who presented in spontaneous labor has been pushing for the last 2.5 hours with no signs of imminent delivery. You are informed by the midwives that the fetal head is occipito-posterior with caput. What is the best initial step of management? Yes, excellent, everyone. So the initial step would be the clinical assessment of the patient. Yes, excellent. So yes, the answer is you clinically assess the woman in the room. Okay, so comes to the question that caused some confusion to some of my friends, and let me explain it. So you are at the labor ward, especially trainee, specialty trainee, and you call to assess a low-risk woman in labor in have 40 weeks of gestation. Fetal membranes ruptured prior to the onset of contraction 12 hours ago. Full dilatation was diagnosed 2 hours ago, and there has been 1 hour of active pushing with descent of the presenting part. Diamorphine was given for analgesia 3 hours ago. Carefully for every word, okay? Your examination reveals that the fetus is cephalic with 0/5 of the head palpable abdominally. You confirm the full dilatation. The fetus in the direct occipito anterior position with no caput or molding of the fetal head. The presenting part is at a station +2 cm below the ischial spine, and the fetal Ctg is pathological with a baseline tachycardia 180 and atypical deceleration. What is the most appropriate management given the above finding? Okay, so the problem here with this question that you know, my dear friends, if I ask you, where is the place of delivery of this patient? Would you deliver in the room or will you deliver in theater? Room, excellent. Okay, so which instrument will you apply in this case? Okay, so we have our friend says forceps, okay, and this will be the non-rotational forceps. It's not outlet forceps because we have either the mid-cavitary or the outlet, okay. It's occipital anterior, yeah. Some of our friends here say that the ventouse, okay, can deliver this patient fast. Yeah, how would it, should I take the decision here? You see that the chances of failure is less in both instrument, right? In the forceps and in the ventouse. Technically and clinically, okay, we can deliver by both instrument, and this would be based on the expert of the operator or the expertise of the operator. Yes, okay, so I'll tell you, my dear friends, here is some factors that with, okay, with the ventouse delivery, here is some factors against the forceps delivery. How? The factors he added here with the ventouse delivery, okay, would be it's easy, okay, so zero head palpable, and fetus is direct occipital anterior, and the presenting part is a station +2. But I'll tell you guys, the factors against the forceps is that the patient only on diamorph analgesia 3 hours ago, there's no epidural, and you know that to apply instrumental delivery, especially for the forceps, you should have adequate analgesia, right? Right, so like effective epidural or pudendal nerve block in place, right? So in this situation, when you don't have effective analgesia and in the same time there is some favorable factors with the ventouse, which one you would go for? Because I know that there is two teams, okay. Yeah, so in this case, okay, that will be the ventouse delivery. Yes, okay, so in this case only, because of absence of effective analgesia and the low chances of failure of the ventouse delivery, okay, ventouse can be applicable here in this situation. The only thing in this scenario against the forceps delivery is the analgesia. Okay, so this is the only thing against the ventouse delivery in this scenario. It's the absence of effective analgesia. Okay, however, how to choose the instrument? Choosing the instrument generally overall, okay, that will be based on the expertise of the operator, no contraindication of the instrument. But the guideline have made it very clear that for the instrument or choice of instrument, it should the instrument with least chances of failure, right? Or least chances of applying sequential instrumentation, right? If I have mid-cavitary delivery, which instrument I will go for? Forceps. If I have rotational delivery, which instrument I will go for? Forceps, right. If I have excessive caput, which one I will go for? Forceps. If I have risk that the child might have some bleeding disorder, okay, here I would like to stop you. Ventouse is completely contraindicated, right? In any bleeding disorder. But I would like to tell you something. Careful when you choose bleeding disorder or risk of bleeding with the instrumental delivery. Why? Because, for example, some cases, okay, it's not absolute. It's according to each case. So if we say mother have thrombocytopenia, will you apply instrumental delivery? Which is the exception, which is the only case of exception in cases of thrombocytopenia, and what is the only instrument that you can use? There is one exception and one only method is applicable. I'm sure that you are very good and you will tell me. Yes, excellent. Gestational thrombocytopenia. Yes, excellent. With platelet count more than 80, so that's why vaginal delivery is allowed. And what type of forceps? Outlet forceps, right? Easy, because they have said avoid traumatic delivery, right? So the traumatic delivery can be low station forceps, non-rotational, or outlet, right? So when it is only easy instrumental vaginal delivery by the ventouse, sorry, by the forceps, you can use it. Ventouse, no, please, okay? Guys, I would like to have a quick revision for this algorithm. What do you think? Okay, so let me do this fast. The assisted vaginal delivery, then go to the thrombocytopenia in 2 minutes. Okay, 1 second, just I'm trying to open my file. 1 second, guys, please. Yeah, thank you very much for waiting. I'm sorry, I'm having some problems in opening the file. So better to go to the website itself. Yeah, it's for some reason the files is not open. Okay. Which one? Yes, thrombocytopenia. Let's have this. And let's have the assisted vaginal delivery. Which one? Okay, 1 second. Okay, we give 1 second till it open. I don't know what's wrong. Still, okay. I'm sorry. Looks like it's in my application to open the PDFs. The defect in my application. I'm sorry, guys. Sorry to keep you waiting. Yeah, the waiting time is for my, the program to open the files. Okay, so let's go to the algorithm. Yeah, this is the algorithm of the utmost importance of your exam. So let's do it again. Regarding the safety criteria for the operative vaginal delivery, remember the contraindication and the prerequisites, right? First, before you decide to use it. Okay, so the contraindication of the instrumental delivery is very important. Can you enumerate some, guys, for me? First is inability to take the mother's consent. This is a very important thing, right? Yeah. This is a very important. Secondly, cervix should be fully dilated. The presentation and the fetal head position should be determined. There is no cephalopelvic disproportion, okay? Bloodborne viral infections are not absolute contraindication, but it's still relative contraindication, okay? So that's mean decision can be taken by consultant, but not on your level. Suspected fetal bleeding disorder or predisposition to fracture are relative contraindication to assisted vaginal delivery. Okay, and you can use ultrasound to determine the fetal head position. This is new in the guideline, so this is something that you should consider. The prerequisites, okay, of the vaginal delivery, the assisted vaginal delivery, is full dilatation. Head position should be at least 1/5 palpable or below. Ruptured membrane, contractions are adequate, consent is taken, bladder is empty, presentation and position are known, station either the spine or below is known, satisfactory analgesia. So this is all to be fulfilled before you attempt vaginal delivery. How to take the decision, when to say, yeah, this is now the time to apply assisted vaginal delivery. How to take the decision is very important. So we have indications for the assisted vaginal delivery. For prolonged second stage, and this guideline refer to the total period of the second stage and not the active phase alone. So he would say for the primary with epidural 3 hours, without epidural it's 2 hours only. Multipara is 2 hours, active and passive. Regional anesthesia, if it is present, or 1 hour without. So what we can remember it's in the primary 3 and 2. 3 for patient with an epidural and 2 for the patient without. Multipara, so it's 2 and 1. 1 for the patient with regional analgesia, 1 for the patient without. So remember 3 and 2, 2 and 1. Okay, this is the important part. Sometimes in the exam he wouldn't refer in the case if there is epidural or not. If it is not mentioned, then it's not present. Okay, so if it's not mentioned clearly that the patient on epidural, so it is not present. This is one thing. Another thing, that sometimes he wouldn't tell you what is the total active and passive second stage, but he will say patient is pushing for 2 hours. So what do you think? Pushing for 2 hours means that most likely she exceed the time, right? So if a primary pushing for 2 hours means that she is now fulfilling the criteria for the assisted vaginal delivery or not? Yes, yes. Okay, so if the mother is exhausted, okay, so sometimes if the mother is exhausted, we can help her with the forceps, not the vacuum. Okay, so exhausted mother, and we have decided or discussed with her that we will apply assisted vaginal delivery. So this can be a forceps, right? If the mother refused to continue, she's exhausted but refused to continue vaginal delivery, so that's mean failure of consent. So that's mean go for cesarean section. So according to the scenario. Medical conditions like, for example, the NEHA class 3 or class 4 for the cardiac disease. Certain medical condition that would be exacerbated by the Valsalva maneuver. Hypertensive crisis is contraindication. Is indication for elective. Cerebrovascular disease, proliferative retinopathy, and take care, there is a question strategy about a patient with non-proliferative retinopathy. Myasthenia gravis and spinal cord injuries. Fetal indication like fetal distress in the second stage, or to assess the delivery in breech for the aftercoming head. So this is all about the decision when to decide to go for the assisted vaginal delivery. Very important to know from this guideline about when the delivery is considered outlet, when we consider it low, and the low is the one that confuses people sometimes. So when the fetal skull station is +2 and not on the perineum, so there is 2 divisions, either non-rotational or rotational. If it is low but rotational, means that will be done in theater or in the room. Theater, yes. If it is low but non-rotational or minimal rotation, that can be done in the room. So we can take a line from here, put a line here, and decide that outlet delivery will be in the room, low delivery will be in the room, rotational row delivery will be in theater, okay, and mid-cavitary delivery should be only in theater, okay. This line also will tell you that for the consent, I can take verbal consent for delivery in the room with documentation, but if it is rotational and done in theater, I should only have a written consent, right? Clear, guys? So let's revise quickly the algorithm. So the algorithm says to select the optimal place at birth, what should you do? Decide first. Continue in the room if the head is low pelvic or outlet, no rotation or rotate easily, no features of CBD, right? So this is what we have just explained. Clear this part, you guys? Is it clear so far? Okay. So when you will consider a trial in theater, if the head is 1/5 palpable abdominally, so the head is means Yes, Dr. Sabah.
Rotated easily, you means less than 45 degree.
Yes,
Okay.
you're welcome, dear. So if the head is in the mid pelvis, so it's in theater. Rotation is required, and again, remember above there it was 45 or more. Okay, so if in the exam he will give you right occipital anterior, posterior, he will give you transverse. Okay, so it will be like obvious that this baby need a rotation. Features suspicious of CBD. This is very important. The feature suspicious of CBD is different from features of CBD. Okay, because features of CBD is contraindication to do a vaginal delivery. Like what features of CBD, which is considered as a contraindication? I would say excessive caput, right? Like caput 3+, for example. Or I would say as well, irreducible molding. So means that the fetal skull bones, when you try to reverse it, when they overlap each other and you try to reverse it, is not reversible. So this is an indication for CBD, and it's a contraindication to try to attempt delivery of this baby. So if you have 1+ caput or 1+ molding, still this is called suspicious of CBD, but you're not sure. Okay, so you will try in theater with facility for immediate CS. The exam question about trial in theater failed. What you will do? Cut 1 CS or cut 2 CS? Guys, you are in theater. You are in theater to perform a vaginal delivery with the CS prepared. The patient have signed the consent plus or minus CS. Would you wait? No waiting, go for the cesarean section. And the baby after failed instrumental delivery or multiple trial is at higher risk of having trauma or distress, right? So please careful. Select optimal instrument. So the selection of instrument depend on first the operator or the supervising operator experience. Number 2 is select instrument least likely to fail, which is generally it's the forceps. Okay, but there is a line in the guideline that says, and I think I had it as a screenshot, okay, in your feedback, in your key answer, that says only in the low station delivery, the probability of failure of ventouse is low. Okay, so the instrument that least likely to fail, avoiding sequential use of instrument, avoid vacuum birth less than 32, and previously it was 34, but now in the guideline 2020 it's 32 of gestation. Use it with caution between 32 to 36, means that even if he give you a baby at 35 weeks, will you go forceps or you will go vacuum? Yes, because the vacuum, yes, it can be used, but with caution. So better to go safe and use the forceps. Okay? Correct application of the instrument. Reassess engagement, position, if you are not able to achieve correct application. Station and asynclitism. So you have to do a reassessment if you're not able to correctly apply the instrument. Seek second opinion if less experienced. Experienced operator to reassess and consider reapplication, change of instrument, or discontinue the procedure. Discontinue the procedure if not achieved the correct application with the above measures. So In the exam, this is again a site of exam question. He will give you a long scenario about you have tried to achieve correct application, you have asked your senior, or you have reassessed and you are sure that everything in place, but still there is difficulty to achieve correct application of the instrument. What shall you do? Discontinue the procedure, right? Yes, abandon the procedure immediately, right? So this is very, very important in your MRCOG questions. Discontinue procedure if not achieve the correct application with the above measures. Okay? Then come to the attempt rotation, which is another famous question in all the previous recalls. If you are unable to achieve rotation easily, so senior obstetrician to check for correct application and correct rotation technique. Sometimes this can be only the option that you obtain senior obstetrician to check for correct application and correct rotation. But if in the scenario you are competent enough, okay, and you have experience to do, or you have asked or whatever, and however, if the rotation is not achieved with the correct application and the correct technique, what shall you do? Again, discontinue. Discontinue the procedure if the rotation is not achieved with the above measures. There is a note saying that birth in direct occipital to posterior position may occur with vacuum or at low station forceps. Okay, however, this is may, so it's not your problem at the moment. Attempt traction and the bolts and number of bolts are very important. So, attempt traction. If there is a progressive descent, then fine. But if progressive descent does not observe it with the appropriate traction, which should be a gentle traction. Number one, check that the instrument is applied correctly. Number two, reassess for features of CPD. Number three, seek second opinion if you are less experienced. Number four, experienced operator may revise the approach, like changing the instrument or alter the direct of the traction. Look here, he highlighted those lines for you and make it in bold. So discontinue procedure if descent not achieved with the above measures. Okay, so if you are trying while you have taken all the precautions, but no progressive descent with gentle traction, what you will do? No progressive descent with gentle traction, and you have done all this, or all measures applied. Discontinue the procedure again. Remember the other option, step number 1, 2, 3, or 4 can be the answer in the exam according to the scenario and option. So please carefully check the question, check that everything is done, that the measures have been revised. Okay, check in the option that second opinion is there or not if you are less experienced. Okay, before you decide to discontinue the procedure. Okay, sometimes he will tell you your consultant is busy in the other theater. Okay, so that's mean no supervisor is attending, so that's mean you will stop, right? No, Dr. Basma, he will not say you are less experienced, but he will say something like you are the new ST3 in the unit. Okay, so this is what he can say. You are new to the unit, or you are new with the instrument and delivery. You are not sure. Okay, so you say something like that. Okay, so discontinue vacuum assisted birth. If there is, how many pop-offs? 2 pop-offs. Okay, so pop-off mainly will be due to some wrong application. Okay, so if you try 2 times and it didn't work, after you have revised your technique and it didn't work, then discontinue, please, procedure. Okay. Reassess after 3 pulls, which is again the MRCOG. The 2 pop-offs are very famous in the MRCOG, and the 3 pulls. So what are the 3 pulls? Consider discontinue the procedure if in the vacuum assisted birth the head is not on the pelvic floor and birth anticipated with maximum 3 gentle pulls to ease over the perineum. Okay, 1 second. What did he say again? He say if you use the vacuum and it applied correctly, no pop off of the vacuum, it is, you know, sealed and it's fine, but you are trying to pull, you have 1, 2, 3 pulls, but it didn't work. Okay, so what should you do? You check and examine. Head now is moved from 0 station to +1 or +2. What shall you do now? Will you continue pulling or will you discontinue the procedure? Yes, discontinue the procedure, discontinue. Why? Because if with the correct application you pulled 3 times and it didn't come, something there prevented from coming. So either a cephalopelvic disproportion or cord or something. So this instrumental delivery is not safe to continue. Okay? Okay? Clear, guys? So if you are using forceps birth and the head is not crowning with birth imminent, so here you will see what's your aim with the 3 pulls, that the head crowning, at least crowning. If the head is not crowning with 3 pulls of forceps, what shall you do? Discontinue the procedure, and by discontinue the procedure is don't try more instrumental delivery, right? Failed attempt, what you will do if you have failed attempt, when it is safe to use another method or another instrument or not. Again, it's in your MRCOG, repeatedly comes. Consider forceps followed by failed vacuum only when with the vertex at low station. So the very famous question in the exam, he will tell you that head moves from 0 at the spine to the position of +1. Will you go for cesarean section or will you go for forceps? Yes, excellent, excellent, my dear champion. It's only cesarean section. Why? Because the vertex is not at the low station yet, right? Okay, so I have low station means it's +2, right? I have progressed from 0 to +2 after failed vacuum, from 0 to +2. Consider forceps, easy, right? So consider forceps failed again, followed by failed vacuum only with the vertex at low station. So when it is +2, if it is, guys, less than +2, please go to the cesarean section. Okay? Increased risk of trauma to the fetus and the obstetric anal sphincter injury with sequential instrumental use. So this is something that we know. Yes, that's why we try to avoid it. Increased morbidity for the mother with a cesarean birth in the second stage. Yes, it's something that we need again to put in mind, that we don't really like the second stage cesarean section, but sometimes we are forced to do it, right? Increased risk of fetal head impaction at the cesarean section. Okay, so that's why we need to inform the neonatologist of the increased risk of neonatal morbidity and complete the operative vaginal delivery performa based on the RCOG performa, debrief the mother, partner, and the family. Clear, guys? Please, after delivery, check paired cord blood sample for the baby. This is another question as well, which is famous. Okay. Patient debrief, incident report, pain management, which would be non-steroidal anti-inflammatory and paracetamol, VTE risk assessment and prophylaxis, exclude voiding retention or difficulty, physiotherapy will be needed and psychological support, and don't forget the antibiotic. Okay, so which type of antibiotic would be given here? Co-amoxiclav, yes, correctly. Okay, so this is to reduce the risk of infection, okay, and which is new in this guideline. In the previous version of the guideline, it wasn't there, right? Well done. Okay, guys, so let me go with you for a quick revision for the thrombocytopenia in like 5 minutes, because thrombocytopenia again is one of the important things that you need to revise for your exam. Okay, a lot of question comes from the thrombocytopenia. Yes, it's easy, but you need to remember to revise this before exam. Okay, so thrombocytopenia, this is something that complicates 8 to 10% of all pregnancy, and the classification will be either mild, moderate, or severe. Mild means that the platelet count is above 100, moderate from 50 to 100, and severe when it is less than 50. So in the pregnancy, most cases are mild and benign, okay, but it can be associated with severe complication for the mother and the baby. The most important clinical point here that when the platelet count is less than 80, okay, so you have to have a discussion with the hematologist, okay, and to decide about the mode of the delivery. Okay, it's very important to see if the vaginal delivery is allowed in this scenarios or not, if the instrumental delivery or the epidural is allowed or not according to the platelet level in each one of them. The possible causes can be from the gestational thrombocytopenia, which is the most common. So he will give you a single best answer question. What is the most common cause of low platelets in pregnancy? Simply, it's the gestational thrombocytopenia, which is physiological and happen with the pregnancy progress. Immune thrombocytopenic purpura, so there is a purpura. This is immune, so it's immune destruction and suppressed production, okay? Or thrombotic thrombocytopenic purpura, which is due to peripheral consumption and microthrombi, which is the most dangerous one of these. Preeclampsia can result in HELLP syndrome, and HELLP syndrome can be associated with low platelets, as all of you know. Okay, some viral infection as well can be there. Okay, sometimes also with severe vitamin B12 or folate deficiency or blood disorder. However, what you need to know and read with care about the gestational thrombocytopenia. It's something that's usually mild to moderate, platelet counts usually above 80, and it's found incidentally during the antenatal care, diagnosis of exclusions, no previous history before pregnancy, no symptoms of bleeding, typically occurred in the third trimester, spontaneous resolution, and may occur in the subsequent pregnancy. What you need to do is consultant led care unit, exclude pathological causes, monitor the platelet count every 4 to 6 weeks, if moderate or severe, anesthetic referral, okay, and avoid traumatic vaginal delivery to minimize maternal risk of hematoma formation. So this is, please, again, avoid traumatic delivery. So when it is a difficult, means in theater delivery, try to avoid it. Cesarean section for obstetric reason only. Epidural is safe, okay, if the platelet count above 80. Excellent. Cesarean section for obstetric reason only, as we said, and if the maternal count below 80, cord sample should be taken at delivery and neonatal count at day 1 and day 4. So management of the neonate of a mother with gestational thrombocytopenia, yes, it's a part 3 task, but again, part 2, you can have it as a question regarding the neonatal management, okay? Postnatal, verify the platelet count, so return back to normal after delivery. For the immune thrombocytopenic purpura, so what you need to remember about it, it's a purpura, so it's associated with bruising, mucosal bleeding, sometimes can be asymptomatic. Again, it's diagnosis of exclusion, but the thing is that the patient from early pregnancy, she had low platelets and there is previous history. Okay, platelet antibody lacks sensitivity and specificity and not required here. Okay, the antibodies can cross the placenta and cause fetal thrombocytopenia. So when you will be afraid from that the baby will have inherited thrombocytopenia in the gestational thrombocytopenia or in the immune thrombocytopenic purpura? In the immune thrombocytopenic purpura. Okay, so which instrument to be avoided in this case if a mother with immune thrombocytopenic purpura? Yes, vacuum and the traumatic delivery. No vacuum, no traumatic delivery. Remember, the mother herself with the immune thrombocytopenic purpura has a risk of bleeding. So the mother herself could suffer if you use a traumatic delivery, right? The management will be MDT with the hematologist, so hematologist should be included. You can optimize the platelets if it's very low before delivery or before, pregnancy by using immunosuppressant or modulators. For example, you can use azathioprine. Monitor platelet count, anesthetic referral, treatment if there is symptoms like purpura or bleeding, and if the platelet count is less than 20 at any stage of pregnancy or less than 50 in late pregnancy without symptoms. So you need to consider the treatment. What is the treatment for immune thrombocytopenic purpura? Number 1 is a steroid. You can go to the immunoglobulins IV, anti-D in Rh positive woman, platelet transfusion, and finally azathioprine. The labor and delivery are very important, so please have the platelets available if you have count less than 50, very important. No, guys, this is a mistake. Focus on the labor and delivery, okay? So have platelets available if they count 50 or less, okay? Please, guys, less than 50, what you need to arrange for the platelets, yes. Generally avoid epidural if less than 80, the same thing like the gestational thrombocytopenia, okay? And avoid traumatic delivery, fetal blood sampling, fetal scalp electrode, cesarean section although has risk of bleeding, but it will be kept for obstetric reason only. Cord sample at the delivery and neonatal platelet count at day 1 and 4. Postnatal, this woman will need platelet check
Excuse
daily
me, ma'am.
until day 2 and 5. Yes, dear?
Ma'am, sorry to interrupt. If a patient is having a thrombocytopenia in the first trimester without any past history or bleeding, can it be gestational thrombocytopenia?
Usually in the first trimester, it would be immune. Usually, okay? So
Okay.
what it's however, it's a diagnosis of exclusion. So what we need to do, you need to exclude other causes.
Okay, but patient is not having any past history of bleeding or bruises, any bleeding history or past history.
Because it could be, even if it's immune, it could be asymptomatic as well. So look to the platelet count, okay? The overall
Okay.
platelet count, and follow up, send to hematology if it is early in the pregnancy. But overall, look to the platelet count and the presentation of the case and the history and the gestational age that she presented with, and then decide. So it's not 100% that gestational should only appear in the 3rd trimester or in the 2nd half of pregnancy, but we should consider other causes than pregnancy if it is appeared early in the 1st trimester.
Okay, ma'am.
We should consider other causes of gestational.
Ma'am, one more doubt about sequential instrumental use. Can we use Wacom after failed forceps?
No, mainly
Okay,
no,
okay.
because yeah, you're welcome, dear. However, look to the assessment of the patient, okay? Usually, if there is no head descent after good application and maximum pull of the forceps delivery, okay, so in this case means that this obstruction is there, so even vacuum will not add anything.
Okay, ma'am. Thank you, ma'am.
You're welcome, dear. Postnatally, guys, this is a good question, dear. Thank you for asking. So postpartum with the immune thrombocytopenic purpura, precautions. The platelet count should be measured daily until day 5, okay, from day 2 to 5. If we have platelet count less than 20 in the mother, what should you do to the baby? Any investigation for the baby? Yes, we count the platelet count for the baby whenever we have a mother with thrombocytopenia, but we will add extra if the platelet count is very low, less than 20, we will add ultrasound of the brain, okay? And we can give immunoglobulins as well. But the transcranial ultrasound is a must before this baby discharged from the hospital, because there is a risk that the antibody bursts the placenta and cause thrombocytopenia to the baby. So if the mother condition is severe, we are afraid that the baby has the same, problem, and the large number of antibodies that affect the mother pass through the placenta and affect the baby. Okay, guys. Okay, so this is the important point that you can have in the exam regarding the thrombocytopenia. I can post this guideline, which is a maternity guideline, okay, to the group, so you can revise it before your exam with a quick look. It's very easy, okay? And I will post as well the answers for the mock test, and hopefully that all the questions will be clear. Okay, thank you, guys. I'll see you tomorrow.